Prabhu, my dear friends from governing body of API, and all the friends who have joined this meeting. At the outset, I would like to pay my reverence to Dr. B.C. Rai, on whose birth and death anniversary we have met together to, I should say, celebrate the Doctor's Day. Rightly, I am proud to tell you that Dr. B.C. Rai was born in Patna. And therefore, we have also some rights on Dr. B.C. Rai because he was born in Patna, but his Karm Kshetra was West Bengal. And there will not be any exaggeration to say that none of the chief ministers in any part of the country has excelled Dr. B.C. Rai. And see the irony or the chance that he was born on 1st July and he left this useless world on 1st July only. In his name, B.C. Rai Award is established, and there are many volumes of, you see, wisdom, freedom fight, quality of his administration, and many more things can be told. And rightly told by Dr. Jyotirmay Paul that we should try to imbibe not only the teachings of Dr. B.C. Rai, but also of all of our great leaders. One of them is again born in West Bengal, that is Subhash Chandra Bose, Rabindranath Tagore, and many more. So we should try to introspect ourselves, look into ourselves, and try to do the best that we can do. It's very simple to be a human, but it's very difficult to be really a human. So we should try to be a good human being rather than a doctor and a person. I wish you all a very good and very nice, blessed day, and good night to all of you. Thank you very much for asking me to be here.
Thank you, sir. Thank you very much. Now I will ask Farik Sahab to say something.
Thank you, Dr. Tiwari. Mr. Dr. Jyotirmay Paul, President, API, Dr. Kamlesh Tiwari, Dean, ICP, and my friends, legends of API, Dr. Thakur, and other friends who are attending this meeting. At the outset, let me congratulate Dr. Kamlesh Tiwari for celebrating Doctor's Day today and keeping the CME program on a very important topic like lifestyle diseases and prevention. So it's a really most appropriate topic of Doctor's Day. And as Dr. Jyoti and Dr. Thakur sir told us that Dr. Vidhan Chandra was not only a great politician, not only was a great doctor, social worker, and a great human being. So friends, it is very true, as Dr. Thakur said, that a good human being can be a good doctor. This is very right. And it is the really people praise today is the day when people praise us and they thank us for our good work, our keeping their health, helping them in maintaining their health and diseases. But it is also very important that at this time, we have also our own introspection is very, very necessary. So friends, let me congratulate all of you, and I extend best wishes to all of you and myself for the Doctor's Day. And again, I thank Dr. Kamlesh Tiwari and ICP Indian College of Physicians, for having such a good CME on such a good topic, because we all know that now the non-communicable disease have surpassed the infectious diseases, and today we lack, and I can say that we blame ourselves for not awareing public about the risks and complications and to how prevent from non-communicable diseases. We all talk in a meetings or in a CME about the diseases, diabetes, hypertension, fatty liver, hypertension, and not lipid. But how this message should go to the public, that is the most important thing. This should be go to the public. I think on that day it is very important to have our press conferences also, so that we can aware the public about these diseases, that they should, because they do not know. We blame them, but they do not know that whether it is need for to take drugs for hypertension or for diabetes for lifelong, or we have to get a regular checkup. So I think this topic will definitely aware ourselves also, our doctors, and to the, if we give this message, we can reach the public. For giving this message to the public, it will be very successful CME program. Thank you very much, Dr. Tiwari, for
Thank you,
giving
sir.
this opportunity.
Thank you,
It was
sir.
a very great honor.
Dr. Grace Mathur, please say something.
Veterans of API, Dr. B.B. Thakur Sahib, Dr. K.K. Parikh Sahib, President API, Dr. Jyotirmay Paul, Dean ICB, Dr. Kamlesh Tiwari, Chairman API Bihar, Dr. P.K. Agrawal, Dr. Sanjay Kumar, and learned faculty of today's program, Dr. D.P. Singh, Dr. Anupam Prakash, and Dr. Puneet Saxena. It's my immense pleasure to join today's scientific program organized on Doctors' Day, a day symbolizing the extreme dedication and commitment of the medical fraternity towards society. I compliment Dean ICB Dr. Kamlesh Tiwari for organizing this program and for choosing a subject very much relevant in present scenario. Lifestyle diseases or non-communicable diseases like cardiovascular disease, diabetes, chronic respiratory diseases, cancer, and mental health conditions are increasing at an alarming pace and are cause of every 7 in 10 deaths worldwide. They kill about 41 million people each year, equivalent to 74% of all deaths globally. We know physical inactivity, unhealthy diet, air pollution, stress, and harmful use of tobacco and alcohol all increases the risk of dying from lifestyle diseases. I'm sure today's learned speaker will enlighten and sensitize us about the gravity of lifestyle diseases and about the lifestyle measures by which we can prevent and control these diseases. I thank the organizers, especially Dr. Kamlesh Tiwari, for giving me the opportunity to join today's program. I wish my best today's success. Thank you so much.
Thank you, sir. Now I think we should start the real CME. The speakers are well known to everybody. There is no need to introduction in this gathering. We are going to start non-communicable disease or lifestyle disease. We know each and everything of these diseases because these diseases not caused by any infection or virus. It is self-made. We create these diseases. Our fault, our behavior, our habit is responsible for these diseases. And most commonly it is obesity, diabetes, hypertension, pollution-related diseases, I mean obstructive diseases. These are common, even cancers and arthritis as well. But today we have chosen only 3 subjects: diabetes, hypertension, and pollution. For diabetes, Dr. Puneet Saxena is going to tell us how to prevent this lifestyle disease, especially diabetes, in this scenario. Dr. Puneet Saxena, please.
Good evening, sir, and thank you very much for the opportunity. It's my pleasure to be on the API platform. And respected Dr. Thakur sir, Dr. Parik sir, Dr. Girish Mathur sir, Dr. Tiwari sir, Dr. Jyotirmoy Paul sir, and all the eminent people present over here. It is such a nice initiative, and I am going to speak very briefly on the diabetes prevention. And it is very important that, sir, can you see my slides?
No, not so far.
No, can't see.
शेयर नहीं है क्या
Yes, now,
Yes.
full screen.
Yeah.
Make it full screen.
Yes, sir. Sir, now they are visible?
Yes.
Yes, yes.
Hello, Dr. Puneet.
Yeah, sir. Thank you, sir. So it's on the prevention of lifestyle diseases, and as sir rightly said, there are so many diseases which can be prevented, but it is pertinent to have prevention for the most killing and the rampant non-communicable diseases like diabetes, hypertension, pollution, and adulteration of food, and so on, and coronary artery disease, and then strokes, and all of them. But I'm going to just have a few, just focus on diabetes and why it is important. Because just see this data, diabetes in India, because we are a nation at the epicenter of a global epidemic. And in the recent IDF, which was held in Thailand in 25, the data was shown, and you can see the global data in 24 that almost 589 million people were affected. And this is about the adults, not the children. And almost this number is going to almost double to 853 million by 2050. And 4 in 5 adults with diabetes live in lower middle income countries, so we are going to be affected the maximally. And you can see the data on the right hand side that we are sitting at number 2 position after China as far as the adult diabetes are concerned. But the unfortunate part is that the proportion of undiagnosed patients is very high. 43% people in India, they are undiagnosed, so maybe they are falling into either pre-diabetes or diabetes which is undiagnosed. And the most worrisome data is the rise in number of type 1 diabetes, which we used to think that because of autoimmune disease it was more common in the western population. But now the number of children adults under 20 living with type 1 diabetes, India is number 1 as per the latest IDF data. So that is again a very something. So for type 1 we can do little about the prevention, although the efforts are on, and there are mechanisms, or you can see even the drugs which can prevent type 1 diabetes. But today we are going to focus mainly on type 2. Why prevention matters? Just because of the sheer number. And if we talk about India, then 101 million with diabetes and 136 according to the our own ICMR in diabetes study, which the results came out in uh, 23. So combined diabetes and pre-diabetes, there we are close to almost 250 million, and 50% remain undiagnosed until the complications set in. The economic burden is US $966 billion globally in 21. And if you talk about the average, one of the studies I was going through a few days back, that the average expenditure of a diabetic in India, as per the surveys done by the pharmaceutical companies, is around 6,000 to 14,000. That is the average amount of expenditure which is being borne by an diabetic who is undergoing treatment in India. And prevention offers the highest return on the investment in the healthcare. So we all know about the natural history of diabetes type 2, where progressive beta cell dysfunction plus insulin resistance plays the role, and that leads to transition from normoglycemia to insulin resistance to pre-diabetes and frank type 2 diabetes, and adipose tissue dysfunction, inflammation, and ectopic fat in liver, muscle, and pancreas cause the main problem. And obesity probably is the main driver for type 2 diabetes in India, along with sedentary lifestyle and lack of physical activity. If you see the risk factors, because if you talk about prevention, then obviously the epidemiology about the risk stratification is paramount importance. And then if you see the modifiable risk factors, obesity stands on the top, and BMI more than 25 for Asians. And you will find that majority of the Indians above 45 years of age, whether you talk about men and women, will fall into this BMI in the middle class and upper middle class and the rich class where there is an affluence. Combined with that, sedentary lifestyle, poor diet in the terms of high calorie consumption, poor nutrient and protein in the diet, high sugars, low fiber, then hypertension, dyslipidemia, and other diseases. And on top of that, infections which riddle the tropical countries. And then you have non-modifiable risk factors like age, family history, and ethnicity, because South Asians at higher risk. So you can see the pyramid over here, that how the risk goes up as the BMI goes up, the lifestyle changes, the diet changes, the tobacco consumption, the alcohol consumption, and all other factors add up, and it leads to frank development of diabetes. So what can we do about the prevention? First is the primordial prevention of the development of the risk factors, where the goal is to prevent the emergence of the risk factors itself, and social, economic, and behavioral conditions that lead to diabetes factors like obesity, sedentary lifestyle, and poor diet needs to be addressed. And the focus is on population at large. You can say the whole Indian population, adult population, can be a focus where you can do interventions even before the risk factors appear. And examples of them is urban planning, promote walking, walkable cities, parks to play for the children, safe cycling infrastructure, food policies where it's sugar taxes, front of pack labeling, the awareness and about the calorie which the children are consuming, restricting junk food, advertising, and more awareness. Recently, we had an initiative by the Prime Minister of India where he spoke that the oil consumption should be reduced. So these are small things, but they matter a lot. And if they are stressed upon, then probably primordial prevention of development of risk factors can lead to a significant change. Cultural shift like promoting traditional healthy diets and active lifestyles. If you are not able to prevent the risk factors, the adult population which has already gone obese has developed, the primary prevention comes into play. And it is prevention of diabetes in high risk individuals, especially those who are sitting on the brink, even at the pre-diabetic stage. And the goal is to prevent the onset of diabetes in people with existing risk factors. And the focus here is the high risk group, like those who are obese, those who are pre-diabetic, those who have family history, those who have hypertension, those females who had history of gestational diabetes mellitus, because we know that almost large chunk of them, almost 50% of them, going to have developed diabetes in the coming years. And the interventions can be lifestyle changes, diet which is low glycemic load, high fiber, Mediterranean or DASH patterns. The overall aim is to have low calorie and nutrient rich, protein rich diet, and the physical activity is 150 to 300 minutes per week is recommended, and 5 to 7% sustained weight loss is recommended in these high risk people to avoid development of diabetes. If we talk about pharmacotherapy in the metformin for those with BMI of more than 35 and those who are less than 60 years or women with GDM history, can be started in the pre-diabetic stage also. And the emerging agents like GLP-1 receptor analogs or SGLT2 inhibitors, which are experimental in prevention, can be used for weight reduction or for high risk reduction in these focused groups. Despite in, you can have digital interventions where mobile health apps, telecounseling. These days, the people are so savvy about the technology, and everybody in India is having his own mobile. So, mobile health apps, telecounseling, and making them aware about the calorie counting, the step counting, the exercise which they are doing can help in preventing the onset of diabetes in this high risk group. And we have models, we have studies, we have the diabetes prevention program of USA, we had the Finnish diabetes prevention study program which came out in 2003. We had in India also a small program in the state of Kerala, where the Kerala diabetes prevention program KDPP was done after the main international diabetes prevention program. So all these have shown us that probably diabetes can be prevented at this very stage also. we are dealing with large numbers of frank diabetics, and secondary prevention at this level comes into play and becomes very important to take care of all those people who have developed diabetes or who are suffering from it. So early detection and management to prevent progression of diabetes and its complications becomes important. And the goal here is early diagnosis of undiagnosed diabetes, because we have seen the data that almost 50% of the people, they don't know they are suffering from diabetes or asymptomatic hyperglycemia to prevent complications. And focused here, people are here with diabetes but without overt complications. And the interventions can be the mass screening, where you can pick the people by various methods, by screening, maybe fasting blood glucose, monitoring them with HbA1c for early diagnosis, and using IDRS, right? And then you can subject them to oral glucose tolerance tests and such things. Then you have to initiate tight glycemic control, those who have been diagnosed, with along with lifestyle and pharmacological management. And please note that the lifestyle is very, very important, and control comorbidities like BP, lipids, smoking, alcohol consumption, and the vaccination and immunization of these diabetics, and diabetic education, where the self-care training, diet counseling, and self-monitoring of blood glucose is very, very important. We all know by the landmark trials, whether it is type 2 or type 1 diabetes, UKPDS or DCCT, which are the landmark trials, or maybe later on trials like Advance and Accord, all those, that tight glycemic control can halt the progression of diabetes and prevent complications. This is the stage where you can think of diabetes remission also. There has been evidence for that. There are strategies, and it is possible. And it is the new paradigm shift in the type 2 diabetes care, where you can select patients for remission. And remission is to maintain HbA1c of less than 6.5% for at least 3 months without glucose lowering medications. And it is the advocacy of all leading diabetic associations across the globe now, that one should try basically for remission of type 2 diabetes. And the shift is here from control of diabetes to remission and to prevention of relapse. Although we know that all type 2 diabetes, they cannot be reversed, but early and intensive interventions can induce remission and can fundamentally change patient outcomes. And the treatment paradigm is evolving from lifelong glycemic control to achieve remission, and followed by sustained support to prevent relapse and long-term complications. And these are the different remission strategies. They can become part of secondary prevention of diabetes. And the first one is the intensive weight loss. So if these are the various mechanisms: the diet, the exercise, the bariatric surgery, and the pharmacological intervention. These are the four pillars which can help in remission strategies. And the first one here is, you can see that the very low calorie diet, where the calorie restriction goes to less than 800, and the low calorie diet where it falls between 800 to 1200, or can be go up to 1500 calories. If these diets are followed, and if some weight loss can be achieved, and the meal composition can be changed. The conventional meal pattern has been that the carbohydrate has to be 55 to 60% of the staple diet every day. But if you can reduce it, you have low carbohydrate diet, where the carbohydrate can be brought down to 10 to 25% of the total diet. So both these things, low carbohydrate diet and low calorie diet, can help in remission of diabetes, as shown by the direct trial also, which was although a small trial, but we all know that this can. And the mechanism is the rapid reduction of the liver and the pancreatic fat, other than the visceral and the subcutaneous fat, reducing the insulin resistance. The second remission strategy can be the bariatric and the metabolic surgery. And we all know that RNY bypass, sleeve gastrectomy, mini gastric bypass, they are the most commonly used metabolic surgeries for diabetes remissions, although they are reserved for morbidly obese patients, because it's a surgical procedure after all. But the biliopancreatic diversion, the kind of surgery, can lead to almost 85 to 100% remission or normalization of the sugar. So remission rates with surgery can go up to 60 to 85% depending on the procedure time. And the mechanism is the weight loss and hormonal changes increase GLP-1, improve insulin sensitivity, reduce hepatic glucose production, and alter gut microbiota. So these all strategies, they are very effective and can be part of secondary prevention of diabetes. The third one is the low carbohydrate and ketogenic diets. Although ketogenic diets have been controversial, and but low carbohydrate diets have shown very clearly that the sugar levels can be brought down and the patients can be brought into the remission. And we all know that stages of remission, they can start from stage 6 and we can move down to stage 0, where people can stay without drugs for prolonged period of time, that is more than a year, without any medication support. So last one is the pharmacological remission strategy, which can be achieved by use of GLP-1 or dual GLP-1 and GIP, the use of SGLT2 inhibitors. So these are the new class of drugs, and the day is not far when probably the guidelines, the national and the international guidelines, will have or will speak about the separate, the identification of the patients who are eligible for diabetes remission with the pharmacological therapy. So the weight loss outcomes with tirzepatide, or for that matter any GLP-1 analog, is significant, and one can achieve weight loss of almost 20 to 25%, which can help in improving insulin sensitivity and glucose control. So secondary prevention is possible nowadays, and which is called as remission, but it is actually secondary prevention. So what happens? Is it the true remission which we can achieve by the pharmacological agents? It is true, but the problem is that once the drugs are stopped, there is a chance that some people will have hyperglycemia, and that is why there is importance of continuing with the lifestyle management in these subset also. So not only the remission of diabetes, but the complications of diabetes can also be controlled and reverted, which was shown by the Look Ahead trial, in which the weight loss and the dietary modifications and remission strategies led to reduction in microvascular and macrovascular complications also, besides the remission by diet, physical activity, and behavior change. So there are factors which can predict successful remission, like the shorter duration of diabetes, that is less than 6%, higher weight loss, that which you can achieve more than 10 to 15%, preserved beta cell function, and lower baseline HbA1c, that is the less than 8%. These is the subset where remission can easily be achieved by any of the modalities which we have discussed up till now. But the challenges are sustainability of remission, high risk of relapse without ongoing support, and requiring lifelong monitoring. The negative predictors are anybody who is having a long-standing diabetes and significant beta cell depletion, and those who have very uncontrolled hyperglycemia, where HbA1c is more than 9 or 10, then it is very difficult to achieve remission in these patients. So this is the summary slide for secondary prevention, where the VLCD, bariatric surgery, the use of drugs, low carb diet, and the lifestyle alone can play a role in secondary prevention. But if you are not able to achieve the remission, or maybe doing enough for secondary prevention, then obviously the tertiary prevention comes into play, where you have to prevent complication and diagnose diabetes. And this holds true for every diabetic which you are treating, whether it is type 1 or type 2. And the goal here is to reduce disability, complications, and premature death in people with established diabetes. And the interventions can be to manage retinopathy, to, to detect nephropathy early, and to use agents to reduce nephropathy like ACE inhibitors, for that matter, calcium channel blockers, or any other cause for non-diabetic kidney disease which is coming and is misdiagnosed as diabetic nephropathy. Neuropathy early detection by simple tests like monofilament test. Then you have to take care about the diabetic foot care, podiatry, and then the comprehensive care can be provided where the multidisciplinary diabetic centers works, and you have a podiatrist, you have a ophthalmologist to see retina, you have somebody who is coming into role when the kidney is involved, and the limb saving surgeries and the cardiac rehab after MI. And not rehab, but evaluation of cardiac health is mandatory, because that is the most common cause for mortality in diabetics. So evaluation is important. And finally, the psychosocial support about managing depression and what do you call as diabetic distress is very, very important. Besides that, there are complications which can ruin the life of the diabetics, like sexual dysfunction, which is not talked about. So one has to manage these patients comprehensively so as to avoid the complications in them at the tertiary care prevention. So to sum up, lifestyle interventions are gold standard as shown by the diabetes prevention program, which came out in 2002 and showed that 58% risk reduction in diabetes with lifestyle versus 31% with metformin. So the lifestyle scores much over the metformin in the early stage, and the subset here was the pre-diabetic subjects. Our own Indian diabetes prevention program, which showed the lifestyle reduced risk by 28.5%, and components are physical training, diet, and weight loss. And please note that only 5 to 7% sustained reduction was aimed at all these diabetes prevention program, whether it was DPP, or whether it is the Kerala diabetes program, or whether it is the Finnish diabetes prevention study. And then pharmacological management, metformin, then GLP-1 receptor agonist, which as shown by the evidence in these steps, surpass and surmount trials, and SGLT2 inhibitors, which have helped diabetics lose weight. And we have seen that the requirement of the anti-diabetic agents have reduced in these patients, those who have used SGLT2 inhibitors. Besides that, technological and digital solutions nowadays, AI-based risk production, digital coaching apps like Gnome, Living, Omada, and wearable CGMs, even for pre-diabetics to monitor basically so that they can made be aware, obese people who can be made aware about the impaired glucose tolerance, and focus on gut microbiome modulation can help in prevention of diabetes. But it is the policy and the public health interventions which will ultimately play a role in the public at large, whether you talk about the WHO's Global Diabetes Compact, or whether it is the advocacy like sugar tax, or pack labeling, or urban planning and promotion of uh, exercise and yoga, how the India is promoting yoga across the globe and taking up the programs like the our own Indian diabetes prevention program, or you can say even the Kerala diabetes prevention program kind of model, and mass screening in the primary care. So with setting up of the NCPDS diabetic clinics across India at every district level, and now Madhuhari clinics for type 1 diabetes across India, and Rajasthan is the first state to launch the type 1 diabetes Madhuhari clinics, where not only the medications will be dispensed, but overall assessment and counseling of the patients will be held. But there are barriers to prevention at the patient level, where you lack of awareness, motivation, and financial constant. At the provider level, where there is clinical inertia at the level of the physicians because of constraint of time, and probably understanding less about the importance of lifestyle modification rather than prescribing drugs. And then at the system level, where the poor policy implementation, focus, and lack of insurance for prevention can play a role. So there is a call to action, especially role of clinicians, where patients of pre-diabetes have to be screened, initiate early lifestyle and diet counseling, diabetes education is must, prescribe drugs as and when necessary, even at the level of the pre-diabetes or early diabetes, and aim for primary, secondary, and tertiary prevention, and collaboration of public health, nutritionists, fitness experts, and advocacy for systemic change is required. So the take-home message is diabetes prevention is clinically effective, economically essential, and ethically imperative. And preventive intervention at every step is essential throughout the course of the disease, whether it is primordial to tertiary, and combining clinical practice with public health policies and interventions is the key to success. And we will see some that day that these things improve and we'll be able to prevent development of diabetes and stop these numbers ticking at large in India. Thank you very much. Thank you.
Thank you, Puneet. Thank you very much. One practical question.
Yes, sir.
Just weight is the major thing. To maintain the weight is the center of prevention for this kind of disease. But suppose a lady of more than 115 kg weight comes into clinic, diabetic, and for weight there are only two means: diet reduction and exercise. So how he will proceed for that? Because she can't do anything. She can't walk even 10 steps because she becomes breathless. She has got osteoarthritis. So what you are going to do in that situation?
Very rightly
What?
answered. But this is the very common problem that you cannot ask somebody who's obese and 60 years of age to run or to do exercise. So that there we have four pillars basically for inducing weight loss and controlling diabetes and putting them into control and probably remission. And the first one is diet. The diet can be very easily taken up by the patient on repeated counseling. That is the major challenge. If somebody is not able to exercise, then probably exercise like resistance training or with the help of the physiotherapist or exercise specialist can be planned. But if that is not possible and somebody is morbidly obese, now there are drugs. You can start with metformin. You have all sort of drugs which can induce weight loss: SGLT2 inhibitors, GLP-1 receptor, dual GLP and GIP-1s. You can plan for bariatric surgery if somebody is willing and can afford. So one has to use all these pillars basically to induce weight loss, which is the main driver for type 2 diabetes.
Thank you. Thank you very much. Now it is the turn of Dr. Anupam Prakash. Is going to tell about modification in hypertension. Dr. Anupam Prakash, please.
Well,
Sir,
thank you.
I
At
want to
the
say something. Just
yes, Dr.
can I
Puneet,
leave, sir?
please.
I have to attend a function at the medical college. So please
Yeah,
excuse me.
yeah. Okay, sir. I know.
Yes, sir. Yes, sir. Thank you very much, sir. Thank you. And all the best, Anupam. And
Well, thank you,
thank you
Dr.
very much,
Puneet. It
whole
will be
API.
difficult to carry forward from where you have left, but anyhow, I will try my best.
Sure, wish you all the best. Thank you. We'll catch up
I
again.
will just
Thank you.
share my slides. Give me a second. So, at the outset, I thank just a second. Yes. I thank the ICP, Dean Dr. Kamlesh Tiwari, sir, President API, Dr. Jyotirmay Pal, and Dean-elect Dr. Girish Mathur, as also our honorable esteemed leader and stalwart Dr. B.B. Thakur and Dr. K.K. Parekh, who are there and who actually have been consistently there through the time with us in all these endeavors. And today happens to be the National Doctors Day, wherein we celebrate the birth of Dr. B.C. Roy. So, with that small thank you note, I will start and try to dwell upon lifestyle diseases, which domain that I have to dwell upon is hypertension. I understand that hypertension is virtually so common that everybody has a fair idea of what he or she deals with. So I will not be talking about the common concepts. I will be talking about something which is new, recent, which we need to be aware about. And I had actually some cases also, but I thought that I would give some new articles which have come and which will emphasize some points which Dr. Puneet has already mentioned. So I would just say that we know this that the rule of halves is there for hypertension. This was propounded in 1972, more than 50 years back. And we all understand that 50% of the hypertensive population, the general population, they are aware of their hypertension status. So 50% are not aware. So that is again, so that is where we need to make awareness and treatment very important. So awareness has to be raised so that people get their blood pressures checked. And half of those who are actually aware that they have hypertension or high blood pressure, they are only taking treatment. And those of them who are taking treatment, only 50% are actually controlled. So awareness is required in general population, also in those who have hypertension. And it is not that people are taking treatment so they are controlled. So awareness is again required for those who are taking treatment to ensure that yes, they have adequate control. Now for that, us physicians also need to be well aware of. And for that, I will just elaborate upon what are the cutoffs, what are the diagnostic endpoints, what are the targets that we should have, and what are the approaches that we need to take care of when we are dealing with a patient of hypertension. So there have been some controversies whether the rule of halves is still valid, but there is a recent article which just suggested that yes, rule of halves is still valid. That is an Indian study which is there. Now, this was 2017 classification, normal, elevated, stage 1, stage 2. And we all understood that yes, BP of less than 120 and 80 systolic and diastolic respectively blood pressure is considered normal. Now, this concept has changed now with the European Society of Cardiology classification. So, I am just mentioning this. And if we had to go over the last half a century, the classifications have changed. It was JNC, the Indian guidelines are also under formulation, and probably by year end, we will have the Indian guidelines also on hypertension. So, this is what is important. If you talk of hypertension, it is not a single elevation which is there. What is defined as hypertension has a persistent elevation of office systolic as well as diastolic blood pressure, which has to be more than 140 millimeter mercury systolic and oblique or diastolic 90 millimeter mercury more than that or equal. Now, if you take, because with some awareness actually has increased in the last couple of decades also. So, those who are having home BP monitoring, the cutoffs you should reduce by 5 millimeter. So, now you have 135 and 85. If the home blood pressure monitoring, it is not the same cutoff. It has to be more than equal to 135 systolic on home BP blood pressure and diastolic more than equal to 85 millimeter mercury. So that is also hypertension. And if you are using ambulatory blood pressure, go again 5 millimeter less. So these are the cutoffs which we should be aware, and these are important from time point. Today, if you have any blood pressure which is more than that, this is classified as hypertension if it is persistent. Now, this I talked about the first point. The second category, just like diabetes, earlier there was a concept of pre-hypertension. The pre-hypertension word has now been changed and it is known as elevated blood pressure. So this blood pressure is considered to be continuum, and elevated blood pressure is now classified as less than what would classify for hypertension. So a blood pressure about 20 millimeters less than the cutoff for systolic blood pressure as well as for diastolic blood pressure. So if you have 120 to 139 millimeter of mercury office blood pressure, this is elevated blood pressure, or diastolic blood pressure 70 to 89 millimeter of mercury, this is elevated blood pressure. Now this recent classification change has changed the terminology. There is nothing called normal blood pressure. So they have changed the terminology. It is now called as non-elevated blood pressure. So since I already said it is a continuum, it is important that you understand that if your blood pressure is less than 120 and diastolic less than 70 millimeter of mercury, it is a non-elevated blood pressure, which is probably better. But the risk is not always zero at this point of time. That is the reason why it is considered a non-elevated blood pressure, and you may still continue advise your patients to have a good lifestyle and dietary modification if there are other risk factors. So this is also very important. So the another concept which is there is, if you have a single blood pressure reading which is high, you need to, or the patient has elevated blood pressure, you need to have a subsequent confirmation maybe in a week's or 2 weeks time by home blood pressure monitoring or an ambulatory blood pressure measurement. This is the recent addition which is important. So an elevated office systolic blood pressure or diastolic blood pressure reading has to be subsequently confirmed by a home blood pressure measurement or an ambulatory blood pressure measurement. So this is the change that is there in the recent guidelines. And if the blood pressure is very high, 160 to 179 millimeter mercury and 90 to 109 millimeter mercury, so that staging stage 1, stage 2 has been removed. But if the blood pressure is high, you have to promptly confirm it. So maybe within a day, or maybe by office home blood pressure the same day, or an ambulatory blood pressure, and call the patient in the next couple of days. So this promptness is not actually defined, but yes, in the next couple of days probably you don't want the patient to be having a sustained blood pressure at such a high level. And if obviously your blood pressure, your patient's blood pressure is more than equal to 180 by 110 millimeter of mercury, you have to rule out hypertensive emergency. So you may need to admit the patient, evaluate for target organ damage, and this is important that you should rule out hypertensive emergency in such patients. Now, another aspect that has been incorporated is stratify. So you have diagnosed hypertension, that is good, but you need to stratify using the score 2 or score 2 up. So the difference between these two scores is age group. So more than 70 years, you use score 2 op, 70 to 90 years, and less than 70 years, 40 to 70 years, you use the score 2 score. Now these are just like ASCVD calculators. So they will tell you the atherosclerotic cardiovascular risk. So if the risk is low, that means less than 5% of a CVD risk in the next 10 years, that is called a low risk. Then you can be comfortable and advise the patient lifestyle modification. You don't need to start pharmacotherapy. I think I have a slide that in the next this thing. So this I already discussed. Continuous risk model. So risk increases steadily across BP levels. There are no clear threshold. That is why normal blood pressure has been given way to elevated, non-elevated blood pressure, and then elevated blood pressure and hypertension. This again concept has now come of using validated devices. So we at Lady Harding Medical College, we are having under the process also, we have some validated devices also. So you need to check now these devices. They should be properly calibrated also. So that concept is now in vogue, and that will be implemented probably in the next couple of years in most of the hospitals or clinics also. And diagnosis confirmation will require multiple readings, and you need to assess both office as well as out of office methods. So out of office methods means home BP monitoring and ambulatory blood pressure monitoring. Now this concept is well known. White coat hypertension, we all know, visiting physician's chamber, the blood pressure rises, and home BP or ambulatory blood pressure is normal. The concept of masked hypertension is also there, wherein although less common but now increasingly being encountered in number of diseases, the office BP is normal and ambulatory or home BP recordings are high. So this is what is masked hypertension, and this is very important that we treat this. Otherwise, the patient will continuously develop target organ damage because of high blood pressure at home but normal in the office BP. This I have discussed already. Home and ambulatory blood pressure monitoring are considered more predictive. Importantly, the night type dipping, the dipper status, that dip is also, the emphasis has been that dip should be retained, and as long as it is there, there is less target organ damage at night. And in those patients who have a very big AM surge, those patients are at greater risk of cardiovascular diseases. So ambulatory blood pressure, we all understand, it is preferred for detecting white coat as well as mass hypertension, and home BP monitoring not only for diagnosis, but once the patient is diagnosed, you should advise your patient to have a blood pressure, a validated or a calibrated device, and that will improve adherence and engagement also with the physician, and better management preventing target organ damage also. This we all know, screening for secondary hypertension. We should it is recommended for patients who develop hypertension in less than 40 years, especially if they are non-obese. If the patients are obese, even essential hypertension can occur at younger ages. And recently, this Sunday, probably people must have read that article that secondary hypertension, especially cons hypertension, is also being seen at a greater than 40 years of age. So that is also true, but you need to have a wider or a greater clinical suspicion to suspect secondary hypertension, because this is treatable if you have a cause. Again, sleep apnea, especially in obese patients. Even in non-obese patients, if they have central obesity, you should think of sleep apnea and always ask. There are questionnaires which are there, which the patient, while waiting for your visit outside your clinics, you can ask the patient to fill up that questionnaire that will tell you whether the patient has sleep apnea or not. Now, this I will just go cursorily because I have some important state later also. It is important that you have a patient of hypertension. Once you make a diagnosis, as the guidelines say, you should evaluate for atherosclerotic cardiovascular disease risk. Again, always screen for target organ damage, be it the brain, the eyes, the heart, the coronaries, the aorta, or the vasculature, and the kidneys, all important because they could be the cause and they could be the effect also. Similarly, apart from evaluating for target organ damage, so you had hypertension, you confirm hypertension. Number two, you calculate the SCVD risk, atherosclerotic cardiovascular disease risk, evaluate for target organ damage. And fourthly, don't forget comorbidities. Screen for diabetes, dyslipidemia, obesity, very, very important. So these are things which you should take care, because you want that your patient should be fine, hale and hearty despite having hypertension. This I will not dwell. We all know cardiac effects, brain effects, kidney damage, peripheral arterial disease, yes, arterial stiffness. Now this is important. Central blood pressure is not equal to brachial blood pressure, and central BP is more predictor of cardiovascular disease. That is why we all probably understand that atenolol went into disrepute, because it was bringing the peripheral blood pressure under control but not lowering the central blood pressure. Now, this is important. For each 5 millimeter mercury reduction in systolic blood pressure, the risk of cardiovascular events decreased by 10%. So, that is the importance of reducing blood pressure. So, you will reduce cardiovascular events, that means myocardial infarction, cardiovascular death, stroke, by 10%. And that is what is high risk. So, any patient ASCVD, atherosclerotic cardiovascular disease risk of more than 10% over the next 10 years is a high risk patient. So, you need to reduce a blood pressure by 5 millimeter mercury to reduce that risk, and this is very, very important. But remember, even if you don't achieve that, even if you achieve a modest blood pressure reduction, it can lead to significant gains in preventing incident or recurrent cardiovascular disease. So don't think that the patient has had a blood pressure reduction of only 2 millimeter mercury. It is still significant, because at times you will find it difficult, what we call as a resistant or difficult to treat hypertension. Now, this is the management approach which I was talking about earlier. If you have elevated blood pressure, that means 120 by 70 and 140 by 90, in between this, plus you have low CVD risk, that means less than 5% risk over the next 10 years as calculated by score criteria, score 2 criteria, or the ACVD risk calculator. You advise for lifestyle changes. But on the contrary, if you have elevated BP and the risk is high to moderate, that means more than 5% or more than 10%, moderate and high risk, then you need to advise your patient for pharmacological treatment after 3 months at least. That means lifestyle would do, but you will need to give pharmacological treatment. And if the blood pressure is hypertensive, now that old adage is gone, that yes, you can give lifestyle management. No lifestyle management, you need to give immediate pharmacological plus lifestyle management. Lifestyle management would stay in all these patients, but you should not wait for pharmacological treatment if the patient is hypertension, because if the blood pressure is high, especially if you have risk factors, you should treat these patients. That is the recommendation which has come with ESC 2024. Now, lifestyle interventions, we all understand sodium restriction, increasing potassium intake, physical activity and weight loss, very important. Dr. Puneet also talked about that in diabetes, but also, yes, in hypertension, also very, very important. Alcohol moderation in only those who are taking alcohol and don't want to quit alcohol. Don't treat it as a lifestyle intervention measure. It is not recommended to start alcohol in moderation. Those who do not want to quit and those who are taking alcohol already, they should come down to moderation levels. And smoking or tobacco has to be omitted. Lifestyle is always recommended whether or not any category is there. Even if the patient is having a non-elevated blood pressure, recommend lifestyle, because that is primordial prevention. The last lecture you would remember. Now, this is a very interesting study. This is published last year only, and I wanted that we should understand this. So, what level of exercise will actually result in blood pressure reduction? And if we increase the blood pressure, many patients will ask, if we increase the blood pressure, if we increase our exercise, will our blood pressure reduce further? Some people will go to the extent of exercising or walking miles together for maybe 1 hour. We had our protocol discussion yesterday only, and people were saying, why will people walk for 1.5 hours? So this is a very interesting study. I wanted to discuss this because this says that there is a non-linear dose dependent decrement in blood pressure, systolic as well as diastolic. And the greatest decrement, that means the reduction, it is not necessary that if you walk for 30 minutes, if you walk for 60 minutes, if you walk for 90 minutes, the reduction in blood pressure will be proportionate. It will reduce, but it will be varying from person to person. And if the maximum reduction in blood pressure is at 2.5 hours, we all understand that it is not easy, but 150-minute walking per week, that means 150 minutes means 2.5 hours, so roughly 30 minutes per day. That would come for 5 days a week. So if you are walking for half an hour. So increasing that dose more than that would not benefit. So 30 minutes per day for 5 days a week. That means 13 to 5, 150 minutes. So if you are walking for 2.5 hours in a week, that is the ideal, because increasing further to that would not benefit blood pressure reduction. So what is recommended in various studies, that yes, you walk for 30 to 35 minutes or 45 minutes on at least 5 days a week. That is probably ideal, and this meta-analysis has actually proved it also. So aerobic exercise can lead to a large and clinically important reduction in blood pressure in dose dependent manner, with greatest reduction at 150 minutes per week. So increasing further to that would not benefit in blood pressure reduction. Maybe there is an individual case which will benefit, but not by and large as per research evidence which is existing on date. Now, this is another study, non-pharmacologic interventions for reducing blood pressure in adults with pre-hypertension so that they don't progress to established hypertension. Now, this says that DASH diet, which is there, which we all understand, diet rich in fiber, nuts, legumes, vegetables, and less in saturated fats and calories, is superior to usual care and all other non-pharmacological interventions in lowering systolic blood pressure as well as diastolic blood pressure. So now this was published in 2020, a little old study as compared to the 2024 meta-analysis, but this clearly says that diet alone, with or without exercise, is probably the most important factor which will benefit apart from pharmacological intervention. So your patients who are not eligible for pharmacotherapy, you should advise diet as number one and exercise as well. So they will together have benefits, and diet alone also has a very, very big benefit and superior to aerobic exercise. That is what this study said. So you have aerobic exercise, isometric training, low sodium and high potassium salt, comprehensive lifestyle modification, salt restriction. We all understood and discussed this in the previous slide, but I'm just telling this study. Meditation, low calorie diet, they all have obvious benefits on BP reduction. But the DASH diet has proven to be, this is again a meta-analysis which showed that DASH diet is far superior to all other interventions. So it is not that you should not advise other interventions, or if your patient is doing other interventions, you should say no. So you have to go off high calorific foods, saturated fats, and increase the low sodium, also increase the potassium and nuts, vegetables and fruits in your diet. Now, this I will not allude to because I know I will be exceeding my time. We all understand pharmacological treatment. First line, you have ACE inhibitors, ARBs, CCBs, thiazides. And if your blood pressure is higher, uh, what was earlier stage 2, probably you should use combination therapy. At times, even in the initial go also, if your patient is hypertensive, now the concept is that you should probably use a combination rather than a single monotherapy, and add beta blockers if there are comorbidities, and prefer single pill combinations, so that ensures compliance and patient is also comfortable and psychotherapy. Now this is what is the target BP goals. So you want that your patient should have 120 to 129 millimeter mercury, that is what is recommended systolic, and a diastolic of 70 to 79 millimeter mercury. Remember, you should not bring down blood pressure to very low levels, especially in the frail elderly, especially patients who have orthostatic hypotension, diabetics, long-standing diabetics, you should be careful, and especially if patients have limited life expectancy, because then your benefits would be less and you will be imposing more risk to these patients. This I have already discussed. Secondary hypertension, you should suspect if less than 30 or less than 40 and more than 55 years, and you have difficult to control BP. We just discussed. I will not go into details. Resistant hypertension, yes, whenever your blood pressure is not controlled on at least three drugs, three plus drugs, with one of which is already a diuretic. So this is important. Special populations, yes. In diabetes, you will have to treat at 130/80. So not at 140/90. CKD also you have similar targets, and avoid nephrotoxic drugs. ACE inhibitors you will have to weigh in whether you need to give or not depending upon what your patient is. Pregnancy, again, avoid ACE inhibitors, avoid, it is an absolute contraindication for ACE inhibitors or ARBs. You don't have to prescribe in pregnancy. And yes, labetalol and methyl dopa, especially if hypertension is related to pregnancy. Elderly, you will need to personalize. We just discussed in the last slide. Now, this is the last concept I will be discussing. The concept is moving from what was clinical or physician driven. Now the care has to be patient driven. It has to be individualized. You have to understand that you have to take the patient as a partner in treatment, because the patient, the compliance has to be at the level of the patient. So that is what is shared decision making. And so you need to guide the patient, you need to offer the patient with therapies and advice, and maybe pros and cons with side effect profile, and ask the patient the compliance also, the cost also. The second concept is promote home monitoring. The third is simplify regimens to improve adherence. As I just mentioned, you use combinations but single pill combinations. And multidisciplinary care, we all understand that. So the last slide, so I would just summarize. Number one, confirm diagnosis with out of office blood pressure. This is an important take home point for all of us. So if you have high or elevated blood pressure, ask the patient to have a home blood pressure or an ambulatory blood pressure and come back after a week or maybe 3 days. The management has to be based on risk, not just BP. So you have high BP or elevated blood pressure, then you have to assess the risk of the patient, the 10-year risk for atherosclerotic cardiovascular disease. Lifestyle, we discussed diet as well as exercise, aerobic exercise, 150 minutes per week are very, very important. And obviously, in addition, you may need to prescribe drugs if the patient is more than 140/90 or in diabetics or CKD 130/80. Those are the criteria for pharmacotherapy, but lifestyle is very essential. And you need to personalize treatment, and regular follow-up is the key, and you will need to emphasize all these points on a regular follow-up. Well, I end this talk, and thank you again to ICP and API for giving me this opportunity to interact on Doctors Day, National Doctors Day. Thank you so much. Thank you. Sir, you are muted, Dr. Kamlesh Tiwari, sir. Dr. Kamlesh Tiwari, sir, आप muted हैं.
Thank you, Dr. Anupam. Just only
Thank you,
one
sir.
question. The role of exercise. After this exercise, are you going to reduce blood pressure or are you going to reduce weight? What is your primary aim?
Sir, you need to reduce weight. If your weight reduces, then definitely your glycemia also improves and your blood pressure also improves.
That's right.
And even if blood pressure and weight are not reducing up after exercise, still activity is very, very important. So I would say activity or exercise is very important, because that brings vitality and vigor to the person. In added benefits, weight reduction. If weight reduces, blood pressure automatically reduces. And third, obviously, if weight will reduce, blood pressure will also reduce.
Yeah, that's right. So weight is the main thing. Weight is the main thing. Reduce weight. Thank you. Thank you.
Weight is the heavy weight or the weighty problem.
Thank you.
Thank you, sir. Thank you so
Now,
much.
next turn is Dr. DP Singh. Pollution is very much common in this time. We are hearing Delhi is polluted, Bangalore is polluted, now Muzaffarpur is also polluted. So Dr. DP Singh will throw light on this subject. Dr. Singh, please.
Thank you, Sher, for giving me this task of speaking on this special day, Doctor's Day. Full screen kar dijiye. Is it visible, sir?
और नीचे जाइए, एक स्लाइड और नीचे जाइए.
This one?
Visible, sir, visible. But
Sir.
it is showing the display.
एक स्लाइड नीचे आइए.
Sir, thank you very much, Dr. Professor Kamlesh Tiwari, sir, and happy Doctor's Day to each one of us, our friend Dr. Anupam Prakash, and all the friends who are attached in this seminar. And this is a very important seminar, and this is a very special day. And we are talking about the global crisis like pollution. Pollution is responsible for 9 million premature deaths annually. 1 out of 6 of all deaths worldwide is due to pollution, while the air pollution contributing to the largest share, 6.5 to 7 million deaths. It means that nearly 99% of the people breathe air that exceeds WHO air quality guideline. And Dr. Anupam Prakash is the victims. Delhi is always very high air quality index. Even Bhagalpur is also sometimes figure in that third or fourth. It is a major risk factor. Air pollution is now among the top global risk factors for death and disease, even surpassing tobacco smoking in annual death rates. WHO 6.7 billion premature deaths per year attributable to combined outdoor and indoor air pollution. And if you see the ambient air pollution caused 4.2 million deaths in 2019, while indoor pollution forming from the cooking fuels 3.2 million deaths, more than 2 lakhs deaths occurring in the children less than 5 years. The Indian burden is that India faces a very severe impact, 1.6 million pollution-related deaths in 2019. That is 18% of all deaths in India. And several Indian cities are consistently ranked among the world top polluted city. Delhi winter quality index reaches 500 or more from the safe limit. 6 of the world top 10 most polluted cities are in India, indicating the magnitude of exposure that air pollution does. Even Bhagalpur sometimes ranks sometimes third in that. So what is the difference between outdoor and indoor air pollution? Outdoor pollution is
sir, your slides are not moving.
not moving.
सर स्लाइड उसमें नहीं है सर, ये प्रेजेंटर मोड पे नहीं है सर, ये
प्रेजेंटर मोड पर लाइए सर उसको।
क्या है, क्या करना पड़ेगा? देखिए, बैक करिए, स्टॉप शेयर कर दें, स्टॉप शेयर कर दें। नहीं, तो बैक करिए, स्लाइडिंग फिर से दोबारा स्लाइडिंग करिए। अच्छा, मूव नहीं कर रहे, मूव नहीं कर रहे।
उसको फुल स्क्रीन कर दीजिए।
फुल स्क्रीन कीजिए।
इज इट मूविंग?
नो, फुल स्क्रीन कीजिए सर पहले प्रेजेंटेशन में।
फुल स्क्रीन तो है।
नहीं नहीं सर, ये अभी साइड व्यू भी आ रहा है आपका।
सर स्लाइड शो मोड पे कर दीजिए, नीचे जो है ना स्लाइड शो मोड पे 100% के बगल में जो आइकन है।
अच्छा, 100%।
स्लाइड शो में जाइए ना सर, स्लाइड शो में।
स्लाइड्स तो करिए, ये तो फुल स्लाइड शो में
नीचे आइए सर, नीचे। हाँ, नीचे नीचे आइए। हाँ, वहां से स्लाइड शो में जाइए।
करिए।
हाँ, वहां से जाइए।
तो इज इट ओके? इज इट मूविंग?
नहीं, स्लाइड शो में अभी नहीं आया सर। तीसरे वाले पर जाइए, उसी नीचे में जाइए। नीचे तीसरा वाला जो सबसे बड़ा वाला स्क्रीन दिखाई दे रहा, नीचे सबसे नीचे फुल कीजिए ना सर, फुल स्लाइड शो में।
इससे लेफ्ट, इसके लेफ्ट 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 लेफ्ट
नहीं नहीं, और
उल्टे हाथ पे।
नहीं नहीं, आप तो उसको वो बड़ा नहीं कीजिए। यहाँ आइए, नीचे आइए, नीचे स्लाइड शो। येलो येलो एक आपका आइकॉन दिखाई दे रहा है, येलो कहीं पर।
हाँ, और थोड़ा सा लेफ्ट, और थोड़ा सा लेफ्ट।
हाँ, और उसके बगल के बगल वाला। हाँ, उसको दबाइए। हाँ, उसी को दबाइए, तीसरे वाले को।
नहीं, तो दबा ही रहे हैं, उसको तो नहीं हो रहा है, ये मूव कर रहा है।
नहीं नहीं नहीं, नहीं हो रहा है सर। उस तीसरे वाले पर जाइए ना, आप अभी पहले वाले पर है येलो।
नहीं सर,
3 उसमें आइकॉन होगा सर, 1 2 3 होगा।
हाँ, तो उसमें तो स्लाइड शो में ही है।
नहीं है सर, है सर। तीसरा वाले पर जाइए ना, तीसरे वाले पर। हाँ, उस पर जाइए, उसी पर।
तो सर स्लाइड व्हाट्सएप कर दो किसी को हम लोगों में से।
व्हाट्सएप कर रहे हैं इनको।
ऊपर में भी है, ऊपर में भी है, ऊपर से भी जा सकते हैं स्लाइड शो मोड में। और ऊपर से ऊपर जो आइकॉन ऊपर जो बना हुआ है सब,
हाँ स्लाइड शो
ये
है।
हाँ स्लाइड शो में जाइए।
ये गए तो सर किसी कस्टम में करेक्ट स्लाइड
फ्रॉम द बिगिनिंग स्लाइड शो।
सर एक बार आप स्टॉप शेयरिंग कीजिए,
नहीं
उसके बाद स्लाइड को बंद कीजिए, फिर से स्लाइड को ओपन कीजिए, देन सर शेयर कीजिए।
ठीक बोल रहे हैं सर, स्टॉप शेयर।
पावर पॉइंट बंद करके फिर से पावर पॉइंट खोल लीजिए।
अच्छा तुरंत सर, एक सेकंड सर, एक मिनट सर। मुझे बानी पढ़ा देना। सर
क्या कहते हैं?
नहीं सर कुछ नहीं, यहाँ है सर, ये नहीं सर, है तो सर करेक्ट। ठीक है, आप शेयर करें तो कॉल कर रखना पड़ेगा।
भूल गए क्या?
नहीं सर, हाँ मैच कर दिए, ठीक।
कॉल कर दो।
शेयर
ओके इसको ठीक करिएगा ना, फुल फुल इसमें है।
फिर स्लाइड शो में नहीं आया अभी।
नहीं सर,
ये
सर
ये स्लाइड शो में है।
नहीं नहीं,
हम तो वही जानते हैं।
ऐसे whether the slide is moving or not?
नो नो।
No?
सर आप अनुपम प्रकाश जी को शेयर कर दीजिए ना, वो वहां से चला देंगे।
तो सर
करिए।
ठीक आनंद नहीं है क्या?
जी सर।
थ्री डॉट्स वाले को शेयर कर दीजिए, वो लोग चला
हेल्प
देगा।
करो ना, हेल्प करो तो।
सर स्लाइड सर व्हाट्सएप कर दीजिए मुझे सर।
बड़ी लाइन कट रहा है भाई।
गर्मी कितना है?
डॉक्टर सी डीपी सिंह व्हाट्सएप कर दीजिए स्लाइड्स।
जी अरे खोल लीजिए तब जरा सर।
Anand, I have sent you. Anand,
सर एक मिनट सर, एक मिनट।
डीपी सिंह को अटक गया।
Either these days, sharing that was not there from my side. Just used to talk physically more.
हाँ, ओके ओके,
Sir,
चलिए सर,
go ahead.
ठीक है।
Go ahead, sir.
This is not full view. Second slide. Anand, move the slide. Yeah. Yes. As I have told you that we are talking about the pollution. After diabetes and hypertension, we are going to talk about pollution, whether this is also a risk factor of the cardiovascular disease or other NCD. The pollution, as you know, is responsible for 1 in 6 of all deaths. Next slide. 99% of the people breathe air that is exceedingly this high polluted air. The major risk factor is that 6.9 million premature deaths due to combined outdoor and indoor pollution. And the ambient outdoor pollution caused 4.2 million deaths in 2019, while indoor pollution, cooking fuels, etc., 3.2 million deaths, including the more than 2 lakhs deaths in children less than. Children are very, very vulnerable to this air pollution. Next. So India's burden. India faces an especially severe impact, 1.6 million pollution related deaths in 2019. Several Indian cities are consistently ranked among the top polluted winter air quality in Delhi. Next. So outdoor pollution and indoor pollution, what is the difference? Outdoor pollution generated by vehicles, industries, power plants, agriculture burning, construction dust, and natural resources. And these are fine particulate matter, that is PM 2.5, nitrogen dioxide, ozone, sulfur dioxide, etc. And outdoor pollution leads to visible smoke in cities and penetrated deep into the lung, causing strokes, respiratory disease, stroke, heart disease, lung cancer, and other respiratory diseases. Next. And indoor pollution resulting from the burning solid fuels like wood, crop waste, dung, coal, and kerosene in open fires, or insufficient stove inside homes. As well as passive smoking is very, very important. Indoor smoke in unventilated space can reach extremely high pollutant level, up to 100 into higher than 5 PM 2.5 concentration than the accepted norms. Around 2.1 billion people, like the 1/3 of the world, is still cooking using the polluted fuels. And this household pollution is responsible for 3.2 million deaths in 2020, more than 2 lakhs children under 5. And it is linked to the same disease as the outdoor pollution. So outdoor pollution and indoor pollution, they are very, very, both are dangerous, causing the stroke, ischemic heart disease, COPD, pneumonia, and lung cancer. Next. Women and children, they are very, very vulnerable. Indoor pollution disproportionately affects women who do not cooking, who are doing the most cooking, and young children. They suffer the greatest health burden from the breathing, cooking, smoke daily. Passive smoking in home is also significant indoor air hazards. Ensuring smoke-free homes and clean cooking practices is vital to protect these vulnerable groups. Next. Next, yeah. And these are as we are talking about the diabetes and hypertension causing the heart attacks and strokes, air pollution is a well-established cardiovascular risk factor. Chronic inhalation of fine particles like PM 2.5 are very dangerous, triggering systemic inflammation, oxidative stress, blood vessel dysfunctions, which contributes to the pathogenesis of atherosclerosis and hypertension. In fact, 68% of air polluted related premature deaths are due to cardiovascular causes. Elevated pollution days have been linked with the spike in the heart attacks. So if the days are polluted, you have got chances of more heart attacks and stroke hospitalization. And these particles, especially the PM2.5, can penetrate the lung barrier, goes into the bloodstream, causing this pathogenesis of endothelial inflammation, increasing coagulation and arrhythmia, and leading to those cardiovascular and other diseases. Next. Indoor pollution impact is very, very high and leading to the significant cardiovascular death. 12% of all ischemic heart disease deaths and 12% of all stroke deaths in certain regions can be attributed to indoor air pollution. Thus, clean cooking fuels can reduce not only the respiratory disease, but also the cardiovascular disease like heart attacks and stroke. Next. Clinical implication is that physicians should recognize that breathing bad air is akin to traditional risk factor like high cholesterol or smoking for cardiovascular disease. So do not ask only these questions of how much cholesterol rise you have got or whether you are smoking or not, but where the area where patients are living, what is the air quality index, what is the air quality or pollution in the home and outdoor, that we have to ask. Next. In chronic respiratory disease, especially the COPD and asthma, is very, very much affected by this invisible killer, that is the air pollution. And that is the COPD is very, very common. Inhaled pollutant causes chronic bronchitis, lung damage, and reduces the lung functions over time. 14% of ambient air pollution deaths occur due to the COPD. Household smoke, that is 19% of COPD deaths in Indian is in adults in the low and middle income group countries attributable to indoor air pollution. Many non-smoking women exposed to kitchen smoke develop COPD in rural India, that is called cook stove COPD. Reducing the biogas mass fuel use has shown the improvement in respiratory disease. Nowadays, gas are available in most of the house, and that has reduced that indoor air pollution. Next. Asthma exacerbation is also very, very common if the air pollution is high level of PM2 and ozone smoke irritate airways, leading to increased emergency visits for asthma. And studies have shown that on smoky days, hospitalization for asthma and bronchitis rises significantly. Children growing up in heavily polluted cities have reduced lung development and functions compared to those in cleaner environment. Next. So what is the takeaway for children? For pulmonary health, air pollution is as damaging as smoking. It causes chronic inflammation of airways and fuels an asthma epidemic, both for provoking attacks and especially possibly increasing new cases. So physicians, especially the pulmonologists, should routinely counsel patients on minimizing pollution exposure to prevent COPD exacerbations and asthma attacks. Next. And this is third very common disease that this pollution can cause, that is the cancer of many areas, but especially the lung cancer. Outdoor air pollution, especially the PM2.5, is officially classified as carcinogenic to human. And this breathing polluted air over years can irritate and promote cancer in the lungs, and much like the cigarette smoking does. Next. Lung air pollution is a significant cause of lung cancers, particularly in non-smokers. So if there is no history of smoking, that even the air pollution will be treated as smoke. Rising lung cancer rates in certain cities is due to high PM2.5 level. Globally, 6% of lung cancer deaths in adults are attributable to exposure to household air pollution. Women in Asia who never smoke but use biogas mass have higher lung cancer rates implicating indoor smoke. Next. So public message is that clean air is essential to cancer prevention. As smoking rates fall, air pollution becomes leading cause of lung cancer worldwide, especially in urban non-smoker. oncologists and primary care doctors should be aware of air pollution as a risk factor and support environmental health measures such as we do for tobacco control. Next. Preventive measures. What preventive measures should we do? Monitor air quality and plan. Pay attention to air quality index reports in your area. High pollution days, advise patients, especially those with asthma, heart disease, and elderly, to limit strenuous outdoor activity. Use protective masks, especially high proficiency masks, should be advised. Improve indoor air quality in polluted city. Indoor environment should be kept as clean as possible. Air purifier with HEPA filters can remove particulate matters in the indoors, but these are not available to everybody. Even simple step like keeping window closed when outdoor air is visibly dirty, that's very important. Use exhaust fan while cooking and ventilation when the air is cleaner, and especially after rains. House plants, that is also been done, like snake plant, spider plant, and pothos are sometimes suggested to improve air quality index, indoor air. They do absorb some pollutants, but their effect is limited in certain normal home setting. Still, greenery in the home can provide psychological benefits and some marginal air clean. Next. Clean cooking and heating. For those using biogas masses, stoves, or kerosene lamps, switching to clean fuel and stoves is crucial. Good ventilation in the kitchen is very, very important. No smoking and avoid second-hand smoke. Reinforce the message that tobacco smoking is dangerous indoor air pollutants. Creating a smoke-free home is one of the simplest way to immediately improve air quality. Do not allow smoking inside homes or car because this will protect the children. For patients who smoke, every clinical encounter should include advice and support to quit and advice and pick the quick date. Next. Waste and dust control is very, very important. Municipal policies must target open burning of wasting. That is very, very common. Alternatively, composting, proper waste collection, waste to energy plants help avoid garbage burning. Construction dust control rules should be followed. Covering sites, spraying water can reduce particulate blow off. In agriculture, providing farmers alternative to crop residue burning. We are very much familiar with this crop burning in northern India. Next. A National Clean Air Program is launched in 2019, and to target is that 131 polluted city of India should reduce to 20 to 30% reduction in PM 2.5 and PM 10 by 2024 and 40% by 2025 to 26. These plans include steps like boosting public support, controlling industrial emissions, promoting cleaner fuels, and public awareness campaign. That is important. And doctors can bolster these efforts by highlighting the health benefit of achieving these pollution reduction targets. Next. A conclusion and take-home message is that air pollution is a pervasive threat to public health, a major driver of lifestyle diseases like heart disease, stroke, COPD, lung cancer, and even diabetes. And it also inflicts irreversible harm on children. Breathing clean air is as fundamental to health as safe drinking water or proper nutrition. Next. The improving air quality still directly reduces the burden of chronic disease. So for physicians, acknowledging air pollution as a modifiable risk factor is important in both clinical practice, patient advice, or in broader advocacy. We should routinely consider environmental history, that is the patient exposure at home or work, and in managing diseases like asthma, coronary artery disease, lung cancer, and even diabetes mellitus. Next. So thank you very much for patient hearing or for the delayed presentation. And I am very much thankful to Dr. Professor Kamlesh Tiwari sir to giving me the opportunity. And I will advise all the physicians taking history in the risk factors always ask about the air pollution, outdoor or indoor. Thank you very much, sir.
Thank you, DP. One question. We all know that we are living in a polluted air. What should we, I mean doctors, should do in day-to-day practice? What
Sir,
should we do?
one of the advice will be that we should start cycling, especially the not we us in our age. Cycling should be promoted in our city, because as we have seen that in the Western countries, Europe, that is a cycle path and people are using it. But nowadays the vehicles are so much increasing on the roads. So we shall advise that the cycling should be taken, and while walking, we should go for the walk, not in the this where the roads are there and busy vehicles are there. That advice we shall take. So cycling and walking in this, and especially when there is
I mean,
stormy
should
days.
we use any type of mask in day-to-day practice?
So it is advisable, as I have told you, if there is polluted atmosphere, indoor and outdoor, we should use mask, not daily, because it is not practicable and people are not feel comfortable, sir.
Thank you, DP. Dr. Sanjay, conclude the session.
Uh, So many thanks to Dr. Kamlesh Tiwari sir and all the three speakers, Dr. Puneet Saxena, Dr. Anupam Prakash and Dr. DP Singh, for a very nice lecture on the lifestyle management or the effect of the behavioral factors on the diseases like diabetes and hypertension. Non-communicable diseases are nowadays becoming the dominant global health challenge due to aging population as well as due to the demographics. And among them, diabetes and hypertension remains key contributor to cardiovascular disease related illness and death. So it needs urgent control strategy at the population level. In a recent study published in PLOS One, using the data from the National Family Health Survey between 2019 and 2021 to assess how unhealthy behaviors are linked to uncontrolled hypertension, it has been found that individuals who are hypertensive have a lot of unhealthy behaviors. And the results found that 49.5% of the men and 36.8% of the women have uncontrolled hypertension. And in men, significant behavioral factors, including alcohol use, high body mass index, and in women also tobacco use, alcohol use, presence of diabetes, high BMI, all were associated with high blood pressure, diabetes, and the morbidity and the mortality. So it all needs to be very much controlled along with the proper medication. So far, so the pollution is concerned, it is again a very important part in deteriorating the diseases. Not only the cancer or the COPD, but it has a generalized inflammatory response in the body, and that can lead to a lot of diseases. So we will have to be very much aware of the pollution. So far, as Dr. DP Singh was telling that even the grade 2 and the grade 3 cities have a very bad air quality index. So we need to be very much cautious. And as Dr. Kamlesh Tiwari was asking about how we doctors can safeguard us from the pollution. So definitely we may wear mask, but not it is always possible. But we may use the air purifier or air microfilters as far as possible. So these measures we can use. So lifestyle modification and behavioral changes are very much important. So far, so these non-communicable diseases are concerned. So again, I thanks the Dean ICP, Dr. Kamlesh Tiwari sir, our faculty, Dr. Puneet Saxena, Dr. Anupam Prakash, and Dr. DP Singh again for very nice deliberation on this topic. Thank you.
Thank you, Sanjay.
Thank you.
Now it is time for thanks. So, Divendu, it is your turn.
Good evening, all. It was such a nice presentation on Doctors' Day. All the doctors are talking about is still talking about the patient's care. So it is nice to see that we discussed the three important topics today. So we are thankful to our Dean Sir, ICP Dean Sir, Dr. Kamlesh Tiwari Sir, and in the absentia, I should thank Dr. Jyotirmay Pal Sir, Dr. Grish Mathur Sir, Dr. KK Parikh Sir, and all the three speakers, Dr. Puneet Sir, Dr. Anupam Prakash Sir, and Dr. DP Singh Sir, Dr. Sanjay Sir, and all the faculties who joined the event today, Dr. Abhishek, Dr. Ramesh Agrawal Sir. So, Sachin, in Doctor's Day, I think wish you all the happiness and good health in the future. Thank you, sir.
Thank you, thank you, thank you very much. तो आज डॉक्टर्स डे मनाया जाए।
हाँ सर,
हाँ जी सर, थैंक यू।
बिल्कुल सर, एकदम मनाया जाए सर।
अनुपम जी मेरा भेज दीजिएगा जल्दी।
हाँ सर, आज रात को नहीं तो कल सवेरे।
ठीक 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 ठीक। एग्जाम शुरू
अभिषेक जी
होने
आपको
वाला
भी,
है।
डॉक्टर संजय कुमार आपको भी हैप्पी डॉक्टर्स डे।
हैप्पी डॉक्टर्स डे
डॉक्टर
अनुपम जी।
जनेंदु हैप्पी डॉक्टर्स डे। एवरीबॉडी
हैप्पी डॉक्टर्स डे सर। थैंक यू
डॉक्टर
सर।
मिश्रा की फोटो नहीं दिख रही है। हाँ डॉक्टर अभेश अग्रवाल आपको भी हैप्पी डॉक्टर्स डे।
सबको हैप्पी डॉक्टर्स डे। सो नाइस, सो नाइस।
ठीक 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 ठीक, थैंक यू।
थैंक यू।